Good morning, everybody, or good afternoon, depending on where you're located. Welcome to our 2018 QPP series, a closer look at the 2018 program changes. My name is Michelle Brunson, and I am a Health IT Advisor with Telligent for the Small, Underserved, and Rural Support Quality Payment Program Resource Center here at Telligent. I work with practices who have 15 or fewer clinicians. Before we get started, I wanted to draw your attention to the chat box. The slides are located at the link there for you to download if you haven't already done so. And if you're having problems seeing that chat box, then you may go to telligentqpp.com. Under Resources, you'll see the link for the slides to download. So I'll close this chat box now. So we are going to talk today for the first in the 2018 Quality Payment Program Series. We thought we'd start with the highlights of the changes. To review those for people that maybe haven't had time to tune into any of the webinars that CMS has provided for you. They've done such a great job, but we know you're all busy. So thank you for taking the time to attend today. And the program changes will look at the differences between the Quality Payment Program Year 1 and the Year 2 requirements as it pertains to the Merit-Based Incentive Payment System, or MIPS. Now, in the next few months, Sandy Swallow and I will go into great detail with each of the categories individually. So the dates for those upcoming webinars will be shown at the end with the registration link for the next one in March. There will be a question and answer session at the end, and I do have my colleague here and my good friend Sandy Swallow with the Telligent QIO to help answer questions too. She works with practices that have 16 or more clinicians and also ACOs, so we might need her expertise as well. Now, everyone's lines are muted today, but we will open those lines up for the questions at the end. And last but not least, we really value your opinion on these webinars. So at the end of today's presentation, you will see a link for a short questionnaire. Please complete this questionnaire so we receive that important feedback and also hear if you have some ideas for future webinars. So thank you in advance for doing so. Now, our primary focus today, like I said, is on the new basics of the Merit-Based Incentive Payment System, or MIPS. Since there is so much to cover, we will not cover the advanced alternative payment models here today. I will discuss with you how you can build on what you learned from Year 1 in the transition year 2017 so that you are prepared for a more robust Year 3 in 2019. And we will explore which steps you can take to be successful this year in 2018. Now, throughout the presentation, you're going to see yellow stars on the slides, and this is really just to bring your attention to something that's either changed from last year or might deserve some special attention for this year. So first of all, there are no changes this year in 2018 for who's eligible to participate in MIPS and who is excluded from MIPS from the 2017 transition year. Everything is the same. You will notice a yellow star under the MIPS excluded clinicians, and this is under the temporary excluded credentials. Now, early on, we expected that other credentialed clinicians would be included by 2019, and the final rule doesn't clarify those expectations, but it just makes reference to a temporary exclusion for these providers for this year. So I just want you to keep this on your radar screen for the near future, that perhaps in 2019 these will be included. We just don't know yet. But the MIPS eligible clinicians are the same. So you'll see those physician types listed there, the PAs, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. Now, CMS has made a significant increase in the low volume threshold exclusion for 2018. So if you are an eligible clinician or a group who billed less than $90,000 with Medicare Part B allowed charges, or you saw less than or equal to 200 Part B Medicare enrolled beneficiaries, you are excluded from MIPS. And this would exclude an additional 134,000 clinicians for 2018. So if we want to flip this around and say, if you are included in MIPS, you would bill more than $90,000 in Medicare allowed charges and see more than 200 Part B Medicare enrolled beneficiaries. So just to flip that around. So this is the exclusion. And this will reduce the burden for many small practices, making them exempt and excluding more eligible clinicians from participation in 18. There continues to be the 2 data runs to determine whether an eligible clinician falls under the low volume threshold for year 2, and those are listed here. CMS is currently diligently calculating the 2018 exclusion for folks, and that information will be made available on the CMS NPI lookup tool on the QPP.cms.gov website. I have a link on the resources page at the end for both the NPI lookup tool as well as the CMS listserv. So it's real important that you sign up for the CMS listserv so you know when important announcements like this are made. And so that will be out there hopefully soon, and we can know for sure who is included. But it is still does apply at the submitting entity level. So if you submit your MIPS measures as an individual, then it will be looking at you individually. Or if you submit your measures as a group, it will look at your group numbers. The low volume threshold opt-in option for 2019 has not been finalized. They are still working on some of the operations on how that might happen, so that will be revisited in the 2019 proposed rule. There will continue to be the same 2 reporting options used for 2018 that were used in 2017, both individually as well as a group reporting. Nothing has changed with those 2 options, but they have also added a 3rd reporting option for 2018, and this is the virtual group. You'll see the yellow star there, and we're going to talk about that next. A virtual group is combining 2 or more TINs made up of solo practitioner and groups of 10 or fewer eligible clinicians that come together virtually to participate as a group, regardless of their location or their specialty. One important item to note is that you must exceed the low volume threshold to participate. And most of the MIPS group policies also apply to virtual groups. CMS put a lot of effort into the inclusion of virtual groups as another participation option, and they've developed a virtual group toolkit with more information, including a fact sheet and detailed information on the election process. So now would be a good time, if you are thinking about participating as a virtual group for 2019, to go out to the link that is included with these slides and look at those pieces of information to see if this is something you might be interested in for next year. What is the potential impact of MIPS for the incentives and the penalties? Essentially, there are no changes from what was written in the last year. The payment adjustment for the 2020 payment year ranges from a negative 5% to a positive 5%, with 5% times the scaling factor not to exceed 3% as required by law. And that scaling factor is really a way for the budget neutrality to be achieved. So the MIPS performance thresholds, they have 15 points. That is the threshold for 2018. Now, this increased from 3 points last year, and this is really a way to get more engagement, but taking a baby step for that. So the eligible clinicians will have many data reporting options or combinations to get the 15 points. I've included some here. For instance, you may report on all the improvement activities. You may meet the Advancing Care Information Base score and submit one quality measure that meets the data completeness. You may also meet the Advancing Care Information Base score and submit one medium-weighted improvement activity, or you may submit 6 quality measures that meet the data completeness criteria. So there are just different ways to get the minimum 15 points, but so there's just some there included. But in addition, I want to draw your attention to the table there. The exceptional bonus threshold points still remains at 70 points for 2018, and the bonus, the exceptional performance bonus of $500 million, again for 2018, with ranges from 1 to 10% applied to your claims in the 2020 payment year for those exceptional performance with more than 70 points. Now, there are different ways to submit data. The ways to submit the data haven't changed, and neither have the expected deadlines, and that's just shown here, the deadlines with the type of mechanism for submitting. A decision was made to continue to only allow one data submission mechanism per performance category for year 2 due to operational reasons. So the multiple submission methods per category is delayed until year 3 in 2019. Now, there is a big change in the weights and the categories. So this year, cost is live at 10% of the category weight for the score. And to get that, they dropped the quality from 60% to 50%. In addition, the advancing care information is still weighted at 25%, and the improvement activity is also still weighted at 15%. So those remain the same. In year 2, you'll see a modest increase for the performance period requirements to include a full year of data for the quality, and that's why you'll see the yellow star there. And the cost performance category is also a full year. There will continue to be a 90-day minimum to a full year for the advancing care information and improvement activity category. Now, remember that the cost category is assessed through the claims that you submit, so there's no data submission required on your part for the cost category. And the other category performance periods remain the same. Now, next up, I want to give you a brief review of the performance category changes and highlights. As I mentioned earlier, Sandy Swallow from the Intelligent Quinn QIO and I will be going into each category's requirements in great detail in this series, beginning with the quality category. We'll start with the March 6th webinar. But I want to talk about the key changes and highlights today. So I'll start with the quality performance category, since this is weighted at the most at 50%. They finalized the weight at 50%. The data completeness, however, increased to 60%, and this is the percentage of reporting the quality action for the measure. So if performance was met, or if it was not met, or if an exclusion applied. So that has increased to 60% this year. If a bigger practice doesn't meet the 60% data completeness requirement, they will earn 1 point. But if you are a small practice, you will earn 3 points. And they expanded these measure stratification classes from 2 to 3 this year. So if you're class 1 measures, they score 3 to 10 points if you have 60% reporting rate and a 20 case minimum. So that remains the same. Class 2, they divided into 2 classes, classes 2 and class 3. So they now stratify class 2 to if you have no benchmark for the measure, or if you have fewer than 20 cases, then you get 3 points. If class 3, if you have less than 60% reporting rate, you get 1 point. But if you are a small practice, then you still get 3 points. So they're trying to allow a little bit more flexibility there. And then also, they have included topped-out measures. They are starting a 4-year phasing-out timeline, starting to remove some topped-out measures. And these do not apply to the CMS web interface measures. Topped-out measures are those that a majority of clinicians are already performing very well. So it's not difficult for them to maybe even score 100%. And so they're looking at these measures and which ones should be removed. Now, the caps will be addressed in the future rulemaking. So, but that is something that you will want to start paying attention to for which measures you reported in 17 and which measures you're reporting in 18 to look at those. Now, the quality Improvement bonus, this is new this year, so there's a yellow star here. And MACRA law requires that MIPS include improvement when calculating quality and cost scores beginning with the program's second year if data is available to measure the improvement. The scoring improvement gives credit to those that may not have met the set achievement targets last year, but they're on their way of making improvement. So if the quality category score improves the opportunity to be rewarded with up to 10% bonus points, the comparison is only to the previous year data at the category level, so not at the measure level, but at the category level. And you must have a full year of data this year. So let's say if your previous year, your quality score, and also if it was under or equal to 30, they use the 30% as a comparison. So that's the bare minimum that they'll use as a comparison. And they will convert that data for comparison if the entities do not match. Now, the calculation is based on statistically significant changes. So it would be this year's score minus last year's score divided by last year's score. And it is, like I said, capped at 10 percentage points. This category percentage score is without the bonus points, by the way. Now for the cost category. This is a big change again, like I said, from 2017. The cost measure is worth 10% this year of your final score. Now, MACRA law mandates that the weight increase to 30% next year for 2019. And so that's why they decided to take a step with a 10% measure. The cost will be measured by 2 cost measures only and no episode measures. So let's just spend a few minutes on the 2 cost measures that are included. Many of you have some experience with those through quality tiering and the value-based modifier program. First of all, there is the total per capita cost. So as your Medicare patient goes through the system during the year, this is the grand total cost of that patient in the entire healthcare system, and then what's the average across the panel of patients. The panel of patients does a attributed list of patients to you or your practice where the plurality of the highest number of services attributed to you. So this is Part A and Part B with a 20-case minimum. Now, please note that specialists are not protected from this if the patient doesn't see a primary care provider and the specialist has the plurality of services. And the second cost measure is the Medicare spending per beneficiary. It's attributed similarly, but at the hospital level. Now, if both measures can be calculated, CMS will take the average of the measure for the performance category score. If only one measure can be calculated, that score will be given the performance category score. And if no measures can be calculated, you will be given a 0 for this performance category score, and that 10% is reweighted to quality so that your quality is equal to 60% instead of 50%. Now, like I said, we did expect episode measures, but Medicare is reworking those, and we should expect them in the coming years. There will be the transition year feedback reports from 2017 available by summer of this year, so MIPS eligible clinicians can see their performance on each cost measure and better understand how the practice improvement changes can drive changes for each specific cost measure. Now, let's talk about the cost category improvement bonus. Because the categories are so unique, they finalize different approaches and methodologies for measuring the quality improvement bonus from the cost improvement bonus. And I talked about how the quality improvement bonus is measured at the category level. Cost is calculated by the measure level improvement. So CMS is looking at the same measure and entity level from the prior year. Both sets must have met the data sufficiency minimums. And please note this can only be a positive bonus. There is a maximum of 1 percentage point that can be earned on this cost improvement bonus. Basically, the improvement score is calculated by the number of cost measures improved. This will be more significant when episode measures are included in future years. But I did add the equation to this slide for those of you who want details on that and how to calculate that. Now, the Advancing Care Information Performance category. Let's move to this category. This is weighted at 25%, and again, that remains the same. There's also no change in the certified EHR technology version that you use, you may still either use the 2014 version or the 2015 version, or a combination of the two for your reporting period that you choose. There is a 10% bonus, however, for those who exclusively use the 2015 edition of your certified EHR technology for your reporting period. So that's quite a significant bonus. And also, there is a 10% bonus for those who use their certified EHR technology for at least one specified improvement activity. And we'll talk a little bit more about those activities, but that is a nice bonus as well. For scoring, there's no changes to the base score. Those have all remained the same. There are exclusions continuing for both the e-prescribing and the health information exchange base point measures. If you have fewer than 100 transitions of care, you would be able to take an exclusion for the health information exchange, or if you write fewer than 100 prescriptions electronically, you would be able to take that exclusion. So there's no changes there. There are changes to the performance score. You are now able to earn 10% for any reporting to any single public health agency or clinical data registry, and this includes immunization registries. So you would get 10 percentage points for that, and then a bonus of 5 percentage points for reporting to at least one additional public health agency or clinical data registry. So that's a nice little bonus there. Now, exceptions do continue in the advancing care information performance category. So your advancing care information, 25% will be related to the quality category, making your advancing care information at 0% if you are have the following exceptions: if you're a hospital-based provider or non-patient facing, ambulatory surgical center-based. Also, there are significant hardship exceptions, and there's also a new significant hardship exception for small practices, and also for decertified EHR technology. If your EHR was decertified, there's also a place for that hardship exception. For the improvement activities category, we're now going to shift to this, and this is weighted at 15%. They added 21 additional activities for the improvement activities category, and they've also made changes to 27 existing activities. So that's quite a significant increase. You can see that they're really trying to amp up this category, and you are still able to get extra credit in the advancing care information category if you use if you have an activity here that uses your certified EHR technology. There are 30 activities in 2018 that you can get that extra 10 percentage bonus points, and it's an increase from 18 activities last year. So they're really trying hard to increase that as well. The performance period remains the same with a continuous 90 days up to a full year. And then if you're a small, rural, or HIPSA practice, you continue to get double the points. So for these practices, you would just need 2 medium-weighted improvement activities or 1 high-weighted improvement activity to get the full percentage points there. And they did increase the percentage of practices to within a 10 for PCMH recognition to get full credit. So you now have to have 50% or more of your practice sites within a 10 to get full credit for the improvement activity category. This slide really serves as a summary of the key scoring additions for 2018. We talked about the opportunity for improvement bonus in both the quality and the cost categories. There are 2 new final score level bonus opportunities. First of all, if you're a small practice, they will add 5 additional points to your final score for small practices of 15 or fewer clinicians, as long as you or your group submits data on at least 1 performance category in the applicable performance period. So just 1 category for a small practice, you would get an additional 5 points. Also, there's an additional 5 points bonus points for caring for complex patients. That's added to the final score, and many lobbied for this, and it'll be based on medical complexity calculated from the hierarchical condition code and the number of dual eligible patients that you treated. So that's also a nice addition. And then also there's an end-to-end reporting. This is not new. It's a bonus that was also provided for 2017, but I thought it was interesting that it's scoped for the first 2 years only. So if you like it, you might want to make sure you make comments to continue this bonus. It's a nice bonus of up to 10% of your denominator for reporting those quality measures. And it does include all types of reporting except, of course, the claim submission measures. Now, there are lots of special populations with special handling and CMS will automatically identify those here on this slide, and we'll put those special populations on the Quality Payment Program website when you use the NPI lookup tool. So you will see those all here, and these are special populations that the details on how these are all determined is in the final rule, but we'll look at now a little graph that provides the special status and a summary of what happens with each category for that special status. So I think this is a nice summary to compare the differences of those for your reference. Now, let's talk a little bit more in particular about the small practice status, because CMS really tried to help those in small practices in a number of different ways, and it is determined for a 1-year period. If you have 15 or fewer eligible clinicians, you are considered a small practice status, and it is determined from claims data. This data is a 12-month size determination period. So for 2018, the small practice status will be determined by claims submitted from 9/1 of 16 to 8/31 of 17. And the different benefits of those who are in a small practice are listed here. First of all, as I mentioned earlier, your improvement activities, you would receive double the points for those improvement activities. You would also be eligible for an advancing care information hardship exception if you did need that for any reason. In addition, you get that small practice bonus of 5 points for just submitting data for at least one category. And then the low volume exclusion, if you meet that criteria, you would be excluded. So if you bill, if you have less than or equal to $90,000 in Medicare Part B charges, or if you see less than 200 patients, you're excluded. So that, like I said, includes another 134,000 clinicians for 2018 that would be excluded. And then also there's that 3-point floor on the quality measures that we discussed. So that's also a nice benefit. And then finally, not just those in small practices, but also those in large practices, you are eligible for technical assistance like myself. For there are 11 CSRS organizations around the country to help you and provide that individualized assistance. Now, I mentioned the MIPS hardship exception application. Now, these exception applications are due by December 31st, and there are significant hardship exception rules that are sprinkled throughout the final rule. The most significant change to this hardship is it applies to all performance categories, not just the advancing care information category. The supported reasons for approval are listed here, and you will note that there is a 5-year limitation that was removed for these hardship exceptions. The only difference is that if you have a decertified EHR technology, that does have an annual renewal limitation of 5 years, and I've noted that there. But that's really a big push to help practices going through hardships and provide that extra additional flexibility. Now, there are so many different key takeaways to success, and like I said, Sandy Fall and I will be going into each of these categories individually, where we will really dive into what is important for you to know for each category. But for these general highlight key takeaways for success, first of all, watch for that revised low-volume threshold update on the CMS MPI lookup tool. And I've included the link there, and you would just enter your NPI, and that will populate. But also, get signed up for those updates from the CMS QPP listserv. And the link to sign up is here. You would just click on that link and scroll all the way to the bottom of the page, enter your email, and then the QPP listserv that you'd like to sign up, and then you'll get all of those updates. So when they do update the 2018 NPI lookup tool with those revised low-volume thresholds, exclusions, you can see those there. And then understand the changes to the categories and the weighting and the increased minimums to avoid the penalty at a bare minimum. Also the new data completeness threshold for the quality category. As a general rule, just plan to continuously improve. You know, this takes work, and we understand that you have so much on your plate. But if you can start off making some stretch goals for 2018 based on how you performed in 2017, if you have an EHR, pull your advancing care information data and quality data often and share that with your team and discuss the progress and really work towards those goals. And please reach out to your small, underserved, or rural support or your Quinn QIO if you're a bigger group or in an ACO for free technical assistance. The link here is takes you to a map where you can look up in your state who would be that organization to help you. And, I have to get signed up for the updates on QPP listserv twice, so we're really going to stress that here today. So those are just a few key takeaways for your success. But also, this 2018 Quality Payment Program Series, a closer look, we have the dates for the upcoming webinars here. And you will notice the first one that we will get into is on March 6th. We will go to a deep dive into quality, as that is 50% of your score, and that is a full year of data that they're going to be looking at. The registration link is here, so you can register there, or you can register by going to the intelligentqpp.com website and go under the Events tab, and you'll see that registration there as well. So then in April, we'll talk about cost, and in May, we'll talk about both the Advancing Care Information and Improvement Activities categories together. These webinars are all going to be held at the same time from 11 a.m. to 12 p.m. Central Time. There are so many resources out on the CMS website. They are currently working diligently to get all of the 2017 resources updated in the 2018 link. And so first of all, the first link takes you to the entire library, where you'll see both the Year 2 fact sheet and executive summary. Then you can click on, there is a link for both 2017 but also 2018. And when you click on the 2018 link, you'll see many different fact sheets out there now, and there will continue to be more and more as the months go on here, and they get those updated. But here's just a few from each one of those categories I thought you might find extremely helpful if you're looking into improving one or the other of those. So some good resources out there right now with many more to come. So now I'm going to open up the lines, and Sandy and I will be here to answer any questions you may have. And one moment, please, here while I do so.
The leader has unmuted your line.
I've opened up all the lines, and so please feel free to ask any questions you may have for us. Does anyone have any questions for us? Don't be shy.
Is there a way to print your slides? I unfortunately joined the meeting late.
Oh, sure. Yeah, sure. If you go here, and I see I have some questions here too. Good. Okay, so right here, do you see the link right there?
Yeah,
on the screen?
I do.
Okay, sorry about that. Go ahead and click there, and then and they're also on the Intelligent QPP website if you go under Resources.
Okay, thank you.
You're welcome. And then it looks like we've got a question here from Jane. If a small practice submits quality measures, 5 of them, with incomplete data completeness, for example, only submits 1 claim, 1 measure, 1 beneficiary, will they receive the 3 points? Yes, that is exactly right, Jane. Because you are part of a small practice with 15 or fewer clinicians, and you don't have that data completeness, then you would still receive the 3 points per measure. Thank you for asking that. Any other questions out there?
Michelle, do you have any tips on how to improve for this year from your improvement measures from last year?
Yes, so I struggled a little bit with this because I could go on and on for different things, but I think the biggest piece, because the quality category is now a full year, it's really important to understand, number one, are you going to use the same submission method that you did last year if you did more than the test pace and you did participate in quality? If so, then then you're going to be, it's a little bit easier because you'll know benchmarking what you're using. Let's say you just used, maybe you used a registry, but your EHR thinks that they might be able to provide that for you. So really have conversations with folks, with your, I'm sorry, I think we're getting a lot of background noise. If you wouldn't mind putting yourself on mute. It might be a cell phone too, yeah. But, so if you're looking at your registry, changing methods, that's a big piece of it. So really know from the beginning and have continual conversations with, like, let's say your EHR is a new method, because you'll want to look at the measures that you chose. And do you still want to choose those measures? Are there any that are topped out that maybe you want to say, okay, I'm going to start using this year because of these potential improvement bonuses, and maybe I'm a small practice and I can get some bonus points, to look at measures that aren't topped out. And then look at those measures, and if I'm able to report those by my submission method. So not all quality measures, can be submitted, as you probably know, for the different submission methods. So let's say in my example, I wanted to use an EHR to submit my data. First of all, is my EHR certified to do this, and can it do this? And if it can, great. Then start running your reports and looking at how you're doing now. Get that baseline, if at all possible, because that's going to be how you're going to determine, okay, if I were to run my baseline, let's say for the month of January, and I see that I'm scoring 40%, I'll go to my quality benchmarks, that link that I provided on my resources tab here, and I'm going to see that 40%, I actually would score 6 points on that, because it's not a topped-out measure. Maybe it's one that not a lot of people have reported on, or maybe with EHR data submission method, I can score more points than, let's say, if I submitted via a registry. So really understanding how you will submit and choosing those measures now. I think that's a very big piece. And because quality is going for a full year, that is where I would start. And then, of course, I could say that with if you do have an EHR and you participated in the Advancing Care Information category, run those numbers now. Run them for the month of January. Share those with everybody and look at ways that you can improve. Just right off the top of my head, I really would suggest getting the patients included with the portal, because not only will you get the points for providing patient access to the portal, but then the more you talk about it, the more that you reference maybe your education documents that are sent out to the portal, then they're going to go out there and view those and download those. Also, another thing is that those transitions of care, make sure that you know what your direct address is, that's that secure email within your EHR. I've heard a lot from practices that they get frustrated when they contact practices that transition patients to them when they ask for their direct address, and it's just an email address from within your EHR that's secure and can send summaries of care to them, that they don't know what they're talking about. So if you don't know what your direct address is, talk with your EHR vendor and find out what that is and how to use that functionality of sending a summary of care electronically. It'll help both you not having to fax those summaries of care, and also the practice to whom you transfer that patient. They will be able to receive those electronically. It'll make that a lot smoother. Sandy, do you have something to add here?
Well, I was just going to add, if you're ready to just implement maybe a healthcare quality improvement project in your office, so you know these are the quality measures I want to use, and these are the ones I want to use every year for the next 2 years, and I want to see these improve. IHI, or the Institute of Healthcare Initiatives, I think is what IHI stands for. They have what's called a QI Essential Toolkit, and it's for, it's got 10 tools and some templates that you can use for launching the quality improvement initiative or project. And I'll try and get the link to that toolkit out here on the chat box for us.
Great. Great point. Yes, and really looking at, you know, those improvement activities that you used and all the brand new activities that they have there. And like I said, CMS doesn't have all of the resources out there yet on the QPP.cms.gov site. When you look under Resources tab, under About and Resources, there will be a link that takes you out to the place where they've housed all of the resources, because there are going to be so many in the years to come. But this is another reason to really make sure you're updated on the CMS listserv. Your email is there, because as they add those new fact sheets and new resources, you'll be notified of that. And so we could also send you information on where those are located in the final rule if you'd like to look at those. And my contact information is right here, and please do so, and I can send you where those new improvement activities are located and where the changes to the existing improvement activities are located. I can't remember the page number off the top of my head. But those would really be, that's a long, long answer, I know, but Sandy and I will be going through these all of these categories in great detail, and then have a lot of key takeaways. I want to share everything all at once, but unfortunately, I don't think I do anybody a service that way. But I will say, to make sure that you reach out to the contact in your state, whether you're a small practice or a bigger practice, for either the small underserved and rural support or the Quinn QIO for the bigger practices, because boy, I have made some incredible contacts with people, and your CSRS organization is really your free technical assistance. We have all been trying to reach out to practices in our states to let them know we exist, and sometimes I don't know if they believe that it's free, but it is. It's free, and to look at your practice individually and how we can help you improve individually. Thank you for that question. That was a great question. How about somebody else? Any other questions?
All right. Unmute it.
Well, if there are no other questions, thank you so much for joining today. There will be a survey link there popping up, so that we ask that you please take this. It really does help us to make these webinars tailored better, and CMS appreciates the comments as well. And then, like I said, these slides are out on the website, and there's a registration link. If you go to the intelligentqpp.com under the resources, you'll see that the slides, and on that page there is a registration link for our next webinar, March 6th, and that will cover the quality category in great detail with the tips and tricks to help you succeed with that. So again, it's from 11 o'clock to 12 o'clock Central Time on March 6th. So we thank you so much. And, oh, wait a minute, I'm sorry. Sandy's pointing me, there's another question here. Can you say more about the hardship exception application applying to participation rather than just ACI? And they really want to make sure that every category does have the option, depending on your particular situation, for quality and for improvement activities. Now, I try to go out there to look to see the application itself. The 2017 application has been closed because it closed as of December 31st, but they don't have the application out there for 2018 yet. The link is there under the Advancing Care Information category, but it's not. And they haven't provided examples yet, Jane, on what that might look like, but I will say the application process seems very simple compared to, if you remember, the EHR incentive program, even more simple than that. So I know they're really trying to make it as simple as possible, and I know part of that, when they release that, they will provide some great examples of what that might look like. I wish I could say what it might look like. I tried to look in the final rule myself, but they just haven't come out with that quite yet. So I anticipate that'll be part of their fact sheets and pieces of information they provide, though. So I wish I could give you a better answer for that right now. From Richard, it asks, is there any statistically significant improvement, no matter how small, sufficient for the quality improvement bonus? They are giving anywhere from 1% to 10% bonus. So, for example, let's say you scored 60% in your 2017 for the full category, and in 2018 you scored 63%, then they would take that 3%, and I'm not going to do this well, but 63 minus 60 is 3%, and then divide that by the 60% to give you a percentage, and then yes, divided by that. So basically any improvement, they really want to give you credit for that. And Sandy's going to add something here too. But
there is an equation in the final rule that does tell you how they'll be measuring that, but I don't have the page on that, but we can try and get that out to you folks too.
And that's Richard that's asking about that, Richard Fairley. And then, let's see here. The quality category. But they really, that bonus is something that they really want to try to give practices something to strive for, and that's why they put it at the category level. So it's not measure specific. So again, 30% minimum would be your base on that. If you scored something less than 30%, they would give you that 30%. But it really is a way to try and incentivize practices out there to work on those. And that's really that key, is understanding what you started at in 17. It's that much more important for making any goal that you can to increase your category percentage for that quality category. But we will get that to you.
There's an equation.
And they give examples in that final rule too, like 5 or 6 examples in a table. And so we'll put that out there. In fact, I'll include that maybe in the slides. I'll add a slide on that where that's located. That might be the best way for everybody to see that. So thank you for that.
And we'll follow up a little bit more on that when we speak about the quality and cost categories.
For sure.
That's a great question.
Do we have any other questions out there? I'll make sure we got everything. Thank you, Sandy. Sandy got the IHI QI Essential Toolkit link there in the chat box as well for the quality initiatives and quality improvement. Okay, well, please keep my information here and give me a call, send me an email with any other questions you may think of afterwards. And we really look forward to having your participation, and we appreciate so much your attending today. And then also, if you wouldn't mind to please complete that questionnaire. Thanks so much, and have a great rest of your day.